Okay, welcome everybody. Come on, record. Now it's recording. Great. Welcome everybody to Perfecting PT. Today we are joined by Emily. Is it pronounced Furry or Ferree?
Ferree. Yeah, actually, your
Ferree.
second pronunciation was perfect. I always tell people it's like referee without the re.
Oh, got it. Yes, we are with Emily Ferree. We are very lucky to have her today. She is a sports physical therapist, primarily dealing with NFL athletes, but also working a lot with Major League Baseball, especially pitchers.
Mhm.
And we're going to be going over some upper and lower quarter kind of cases, preferences, really get her professional take on this and really give her a chance to tell everyone what she finds most useful and best for these populations. So anything you'd like to start us off with, Emily, as far as introduction wise, anything about you before we kind of talk about the stuff we covered pre starting recording?
Yeah, I'll just kind of give a quick intro of my
Sure.
background. So I graduated from physical therapy school in 2016 from USC. So I did my undergrad and my doctorate degree there. So I'm a double Trojan, fight on. I got a job right out of school in a kind of sports performance facility, and I did some specialized training in biomechanics. So that kind of always became a big part of my practice initially. Um, People always want to ask how I got into professional sports, so I'll just kind of intro that a little
Sure.
bit. And so the clinic that I got a job at out of school had a contract with an NFL agency called Athletes First to do combine and pre-draft prep. So college football players who were declaring for the draft, they put together basically a 2 to 3 month program where they prepare them for either the combine or pro days, which for anybody that doesn't know what that is, basically when players are getting looked at to be drafted into the NFL, there's what's called the combine, which is a series of athletic tests and measures where scouts, coaches, GMs all come and they just watch these players compete with these specific tests. So we know exactly what these players need to prepare for, and they don't correlate perfectly with playing football. So a lot of these players come out of their college seasons and they're in shape to play football and they're prepared for, all their position specific drills, movements, things like that. But the combine is a measure of your 40-yard dash, your vertical jump, your broad jump, what's called a 5-10-5 or a 3-cone drill, and then the L drill. So it's very specific, kind of like ballistic strength and agility measures, and then obviously a bench press test.
Mm-hmm.
So it's essentially a track meet. And these athletes are looking to look really good at this meet because there's like essentially a portion of the combine where you like stand up there in your underwear and get measured and looked at and your wingspan. So they need to look really
Really?
good for that. Yes, it's like a meat market. It's so strange, but it happens.
Okay.
And so they need to look really good. They need to be really fast and they need to be really strong at these like very specific events
Mm-hmm.
that, as you know, sometimes we have first round draft picks who are incredible on the football field and their film's incredible, but they may not test super well at these specific events, which could hurt them if they go to the combine and then don't test well. So it's a very specific training program to get them ready for this very specific like week-long event where they have to compete. Um, so I was doing that process with an NFL agency. And so my very first year working, started working with some of these guys. And then one of the players that I was working with in this combine pre-draft process ended up signing with the Chargers, who were the team that's local to us where I'm at. And so when he was actually playing for the team, he came back to work with me because he had a relationship with me at that point. And then he referred another player in, who referred another player in, who referred another player in. And it just kind of blew up from word of mouth in that point. So we always say in sports, it really matters who you know, because
Mm-hmm.
that first step in is generally always going to be from a connection that you have professionally.
Sure.
But then you have to be ready for the opportunity, right? So you have to perform once the opportunity comes, and then that's how athletes are going to trust you. So I also generally tell people you don't get a second chance with an athlete. You get a first impression and a first impression only. So first impression's got to be good because they're not going to waste their time and they're not going to risk their body. So their
Right.
first interaction with you has to be a positive one and they have to feel like you kind of make a difference for them and they'll come back. But if you kind of flub that first interaction, it's really hard to get a second chance, essentially. So that's how I got started with the football stuff. And then on the baseball end of things, some of my final training at USC one of my last clinical rotations was in a lab, Chris Powers lab, that does clinical biomechanics. They
Okay.
use research grade biomechanical equipment in a lab, and their whole treatment philosophy is based off of changing the way people move. So they do evaluations of running, cutting, jumping, all that kind of stuff, and strength. And then it's when I was there, it's changed a little bit now, but when I was there, it was a no manual clinic. You did not touch your patients. You just strengthened them and changed their movement patterns. So it was a
Sure.
really unique treatment philosophy. I enjoyed it a lot. I love the sports science side of the biomechanical evaluations. And I love that it was kind of like a really getting to the root source of why someone got injured in the first place and not just treating symptoms. And then, so the reason I got hired at that clinic initially out of school was because the owner of that clinic went through Chris Powers' fellowship program and was building a
Mm.
biomechanics lab himself and needed somebody who knew biomechanics to run his lab for him.
Sure.
And so, and so with that lab, I ended up actually traveling to Germany to learn how to do all the 3D kinematics and 3D data analytics. And that's what got me into baseball and throwing. So obviously pitching is a three-dimensional rotational movement.
Hmm.
So it's a little bit different than evaluating like running, cutting, and jumping, which is more two-dimensional. Um, and just started like pulling in baseball players from the community to learn as much as I could. And that kind of connected me to other coaches and pitching development guys that were in the area, and everything kind of, again, just word of mouth flew from there. And then eventually I started kind of consulting for some MLB teams and evaluating more professional pitchers and things like that. So that's kind of what pigeonholed me towards pitching in the biomechanics world. And then the combine stuff is kind of what led me into the NFL stuff. So that was kind of the path that got me here. I know that was a lot. So if you have any specific questions.
No, that was great. Like really, I don't really have a lot of specific stuff. I mean, I have a general direction I want to go, but I want people to know about you. Like I really have no prerogative other than trying to present you in your best self to other people so that they can benefit from what you
Yeah.
do and potentially get connected so we can build a network that is just better than the current networking community that we have in
Yeah.
sports rehab.
I really like that you say that. I actually just sat on a panel for a physical therapy school in New Hampshire. They
Mhm.
found me via Instagram and asked if I would, they have like a sports interest club where they're talking about getting into sports PT. And so they asked me to come and speak. And someone asked me, like, why do you do social media? And I'll be the first to say, I'm not like great at social media. It's not my natural inclination. And like, I'm kind of learning as I go. I literally had to ask one of my
Same.
NFL players, like, how do I even look at the stories and get people's responses? Like, I'm not naturally a social media person. It's not my natural inclination to like record the things that I'm doing. But the reason that I do it is because, like I said before, so much of sports, fortunately or unfortunately, is who you know. And if
Hmm.
you don't have somebody in the sports world that you know, like how do you get a leg in? It's so hard. And it's, especially, I would say, too, like as women in this industry. So the whole point of my social media is I hopefully want to be the person in sports that people know, even if they just know me through social media, because those connections help. And I have athletes who ask me for PTs. They travel all over the country. They go back home for a couple weeks, or they are at a new team in a new city and they need physical therapists. So for me, it's not helpful to have a network of PTs that I know and can trust, that I can refer people to. But two, like I've gotten so many questions about like what to do and how to do it to get into the sports world. I think it's helpful to have somebody essentially that that can like give you that leg up into the world, give you that introduction. Because I think there's this kind of big screen in the sports world of like, how do you get in? And that's the primary question I get on my social media is how do you get into the sports world? And so I'm hoping to kind of demystify getting into sports a little bit, because it is unique, but it is super accessible.
Sure. As well, it's kind of it's like a bottleneck. It's like as soon as you get through that like opening of finding a person, it kind of broadens, especially like you said, if you're semi-competent and are providing good care, make good first impressions and get athletes and other people the results that they want.
Yep. Yeah, 100%. If you do good work, athletes will trust you. The big hurdle is you have to get that first athlete in. And so what I always tell people is athletes don't just like stumble to any like typical physical therapy space. Like they don't just Google like physical therapy clinics in their area. They are
Mhm.
going based on direct referral, and it's generally coming from a teammate, an agent. If they had surgery, their surgeon, or a sports performance coach that they're working for. So you have to have a connection to one of those 4 people who are going to say, hey, Nate's an amazing PT that I know. You should go see him. They really only count on personal referrals because, like I said, their body's so important to them. So they're either looking for a teammate or somebody in their position that's had a good experience with you, or somebody
Mhm.
they trust, like their agent, their surgeon, or their coach who's going to refer to you. So I always tell people, if you want to get in, be in either a sports performance facility that has a training component to it, that has some sort of performance component to it. So you're with people who are already training athletes that can then refer to you. Or you have to find a way to make those connections, like I said, with agents, with surgeons who are going to refer athletes to you.
Sure. And I missed something. So for anyone listening, I've been asked that I am not always as clear as I should be as far as what we're going to cover today. So I brought up upper and lower quarter.
Mhm.
We've gotten a lot of questions. So for anyone listening, we are going to go through an upper quarter case, probably specifically the shoulder. A lot of people are very interested in the shoulder, and we'll probably do a lower quarter case as well. I think probably most athletes that are getting messed up, it's probably a knee. As far as hip and ankle contribution to that knee or other things going on with it, we'll probably talk about that as well. We're really going to try to hammer into, how do you know when my athlete is ready to progress? And most importantly, how do I know, or what gives me the best chance of knowing my athlete is ready to return to practice, and in what capacity, and eventually to the game? And that's a big reason I wanted to talk to Emily, is because especially with NFL athletes, you have to be ready for that, especially leg or anything else, for trauma, repeated, regular, high impact trauma from people that want to kill you. And
Great way to describe it, honestly.
well, right. And so you really get the trauma, like repeated high impact trauma on the football side. And then you get high force, repetitive motion overuse on the shoulder side, particularly from pitchers who are going to rip, 60 to 100 pitches in a game at, varying between 70 and 100 miles an hour. Like, that's a lot of stress through the joint. So I'm really excited to talk more biomechanics. I find the more people I know, the less they're like, oh, it's just the rotator cuff, or oh, it's just this. And it's like, biomechanics is a system. Like, it is a system of how the body wants to move. And so many people are like, treat the hip. And PT school's like, treat the hip, treat the knee. And it's like, yeah, but what is influencing how that knee moves elsewhere? So I'm excited to get into that. And for anyone
Yeah.
else still wondering, we're also going to chat for a little bit. Obviously, we are not physicians, but we're also going to chat cortisone and PRP a little bit, because there's a lot of athletes that are like, well, the doc offered me a cortisone injection, or they're thinking about doing PRP and rehab. And so we're going to try to get you a better idea of that as well. So I think first things first, Emily, I'd really like to know kind of, what is your training philosophy? Like, people come in your clinic, you're kind of marketing yourself to this athlete for the first time. I'm sure you have some pitch that's kind of like, this is how I do things. Like, this
Yeah.
is how I view things. I'd really like to know that. And then if it's okay, we can pick, we'll just go lower quarter first into like how you go about that.
For sure. I think my pitch changes a little bit depending on what time of year it is. And so is the
Okay.
athlete off season? Are they in season? Because what they need changes a little bit. So
Sure.
if an athlete, let's take an NFL athlete, for example, if they are in season, my pitch tends to be that we are going to take care of you like 360. So we're going to take care of all the wear and tear from practice and games and keeping your body recovered. We're going to take care of little nagging things before they become big injuries so you don't have to miss time. And then we're going to do our best to kind of assess you to figure out where your weak points are. Not necessarily like specifically weak. I would never tell an NFL athlete like, hey, you're weak.
Mhm.
But kind of where like the chinks in your armor are that might be setting you up for injury. And we can address those before they become an issue. So in season, we're really looking at taking care of recovery, maintenance, body work, and then addressing injuries before they become big issues. But then I also say, now you already have a relationship with me. I get to know your body. We're working on a regular basis. If you do get injured, we're really set up to rehab, recover at a more quick rate because you and I are both familiar with what your body needs and how it works. And we already have that relationship. And so basically, we can take care of anything as it comes up. In the off season, my pitch to athletes is, listen, we're going to create a whole strength and conditioning program for you. We know exactly what the season requires. But also, if you've been working with me, During the season, we have a good idea of the nitpicky things, the little nagging injuries that you kind of dealt with all year. So we know specifically what we need to build up, what we need to train, what we need to protect to make sure that these things aren't nagging issues in the season to come. So that's kind of generally my kind of whole pitch to an athlete who's going to be working with me year round. I think that's the other unique thing with sports is in general people come to you with a pain or an injury and you evaluate, you rehab, and then as soon as they're ready to return to play, you don't see them anymore. You discharge
Mhm.
them. In my experience in the professional sports world, you never really discharge an athlete. You're continuing to work with them. So even my guys who are on, let's say IR, and we're rehabbing like
What
a
is
season-ending
IR?
injury. IR is injured reserve. So if
Injured
an
reserve. Okay.
athlete Yeah, so if in the NFL, if an athlete gets designated on IR, they can either be on short-term IR or season-ending IR. So short-term IR is a minimum of 4 weeks that they cannot practice with the team and they're not playing. And then they can designate, so they can be on it a little bit longer than that, but it's minimum 4 weeks.
Okay.
So, and if you're on season-ending IR, so let's say you have an ACL injury or you broke your leg or, whole myriad, you have to have surgery for some reason, then you're out for the whole season. So either way, if you're on IR, you cannot participate in practice or obviously games. And so if an athlete, so they're in a full like rehab protocol, so they don't have to go to practice. If they are rehabbing outside the team, which is their right, they don't really even have to be in the building. So they're kind of separate from the team at that point.
Okay.
But if they are rehabbing with the team, they can still really be a part of the program. They just can't be at practice, basically. Um, but all that to say, so if you're rehabbing somebody, even when they go to return to play, they still come back and we're still working together because now we're back to working on the maintenance issues, the recovery issues, making sure that that injury, whatever it is, continues to hold up and be strong and all those things. So it's you end up with this like kind of year long ebb and flow of what you're working on with these athletes. And so the more time an athlete spends with me, especially kind of in that whole year cycle, the better their off-season programming is going to be because we knew exactly what their issue was during season. And then during season, the better their recovery and rehab is going to be because I already kind of know the issues that would come up. So there's certain things that like every time they come in, for example, I might have a linebacker that every time they come in, I'm doing hip mobs for them because I know that this is going to be an issue that continues to come up. And this is not just part of their maintenance program. We mobilize their ankles and their hips and then before we do anything, because this is always going to be their issue. And this is just their base program that we know to work with. So there's some value for those athletes to kind of stick with me year round, whether they're injured or healthy, just to kind of be in optimal shape, essentially.
Sure.
And
So
then,
sorry, I didn't mean
oh,
to
sorry,
interrupt.
go ahead. I was
Oh,
just gonna say on the baseball end, kind of my pitch for my philosophy is
okay.
um, before I throw you on a table and evaluate your range, your strength, all this kind of stuff, I always look at your movement first. I always look at your delivery first. So there's not a lot of tests and measures that we have as physical therapists that directly correlate with what happens during a pitching delivery. It
Agreed.
is too fast, it's too
Mhm.
dynamic, it is at too extreme of a range of motion. So a lot of times, like I will test a range of motion and they will get more than that in their delivery because of the
Sure.
position their body's in, because of the huge stretch relax cycle that some of these soft tissues are going through. I mean, so many things. And the amount of torque that's going through their body that's forcing certain joints in different ranges of motion. It's just so hard to correlate a static evaluation or a low speed, even a dynamic low speed evaluation to what a pitcher actually does. That I can find 1,000 things, quote unquote, wrong with a pitcher or not optimal, and none of them might correlate with the issue that they're having. So we always look at their delivery first. Now I understand that everybody has a biomechanics lab to do that, but
Mhm.
you have game video. Most of the, if you're getting a professional pitcher, a lot of them have their data from the labs that they're working in with their teams that you can look at, or even like if it's a high school or adolescent athlete, a lot of them like their parents have slow mo video on their iPhones. Like there is a way that you can actually look at the way that they're moving, even if you don't have a biomechanics lab. Um, but so I say we're going to look at the way you move first because that tells us why you are set up for injury or why you're having performance issues before I just throw you on a table and find 18 things wrong and now we don't know where to go. It's kind of like that shotgun approach, right? Like I can pick out 18 things that aren't optimal in your body, but which one of those actually correlates with your issue?
Sure. So let's just do upper extremity first because we seem to already
Mhm.
be there. So when you're doing an analysis of someone who has shoulder and let's, I know we're going to talk pitchers specifically, But I
Mhm.
find that a lot of the people who have shoulder issues, I played men's volleyball, a couple of my sisters played college, like a lot of like high speed overhead at motions. You have a lot of pickleball people who are just are swinging hard. It would
Yeah.
seem that from your standpoint, you want to view how they are performing first.
Mhm.
When you are recording, what are you just doing, like straight to the side, straight ahead, above? Like what are these ideally the views that you want to see of them performing their motion?
So, first I'll say I am privileged with the biomechanics lab. So we have an 8 camera system. So I get 8
Okay.
different views of the athlete.
Okay.
If you don't have that, I would say for pitching specifically, the two most important views would be the open side view.
Okay.
So as they're kind of in that full stride, so the open side. So if they're a right-handed pitcher, looking at them from like third base, if they're a left-handed pitcher, looking at them from first base,
Okay.
and then either the straight on front or straight on back view.
Okay.
Those would be the two most important ones. I would say it's probably the same for pickleball, volleyball, any sort of like overhead athlete. I would say those two views are most important. And those, even with my 8 camera system, those are the two views that I look at the most. The one
Hmm.
after that is we have a camera view it's like a bird's eye view. It's directly overhead.
Hmm.
And I like that one as well because as far as the rotational aspect, it really gives you a good idea of the timing of when each segment opens and how much disconnection and separation they get. But again, not everybody has access to that. So the open side view and either the straight on front or straight on back view are, I think, the two most important.
Sure. And what so and I know this, like you could write an entire book about just this next question, but what are you looking for? And we'll just stick to pitching because that's what you do.
Yeah.
But like what are you really looking for that you're like, this will be a problem? And maybe I'll preface that with, for anyone, people out there that are like, it doesn't matter how you move, you just need to be strong and flexible. Like I'm gonna say that that's a hard from me on this. Like we know at the highest level, like your hips should do this much, your spine should do that much, your shoulders should do this much. And if any of those does less or more, it will predispose certain things to having issues. So I'll kind of preface that. And Emily may say, Nate, you're an idiot. You're wrong. And I'm okay with that. Um, I'm curious what your thoughts are.
Yeah, no, I would agree with you, Nate, that there are certain things that we know that if pitchers are doing them from a movement standpoint, they are at higher risk for injury. So the big ones are how well they use their back leg. So a
Okay.
lot of shoulder and elbow injuries happen because of back leg mechanics. So in what direction are they creating force? Is it very linear? Is it rotational? What's the timing of how they create that force? So I'm looking at basically the timing of when the back leg starts to abduct and extend versus when it starts to internally rotate.
Okay.
We're looking at the foot. So when they get up into peak knee height, where's their center of mass? Are they all the way back on their heel? Are they all the way up on their toe? Or are they right in the middle of their foot? That gives you an idea, as you know, obviously, where their center of mass is going to direct where the torque happens. So if you're all the way on your heel, it's really hard to create rotational torque. If you're all the way on the toe, you're going to be really quad dominant. Whereas if your weight's in the middle of your foot, you can actually kind of create rotation around that central axis of your midfoot. Um, we are looking from a stride perspective, how far they stride. Now, there's generally been like a percent of body height that we used to go by. I don't go by that anymore. I think that's more specific to a pitcher's range of motion. So you'll start to see things get pulled open way too soon, and you'll start to see them lose hip to shoulder separation if they're striding too far. So if they're striding so far that they run out of room, things have to get pulled along with it, things fall apart. So we're more looking at stride length as a function of how well they can block with their front leg and how well they can separate. The other big thing that we're looking for from an arm health standpoint is, does the arm rotate on plane with the torso? So what we know from the transfer of kinetic energy, the transfer of angular momentum, so your pitching is rotational, we're
Mhm.
creating rotational angular momentum. And so the axis at which your torso is rotating, you want your arm to kind of unwind and rotate on that same axis. If it doesn't, you're going to lose some energy transfer. You're going to create deceleration in the arm when you should be creating acceleration, which is going to increase the torque on your shoulder and on your elbow. So extra torque on the shoulder and elbow is what creates the strain that causes injury. So we're looking for basically release angle. Does it match? Essentially, if you drew a line from shoulder joint center to shoulder joint center, do your shoulders line up with your arm at release?
Okay.
The other thing we're looking for from an elbow health standpoint is how well the pitcher can get the ball inside of 90. So when they pull in, so get in the view here.
Yep.
So when they pull the ball inside their elbow, so the timing of that as they rotate, if when they pull the ball up into cocking, if they never get inside of 90, we do know that that places increased strain at the elbow as well, specifically that varus torque that affects the UCL. And then at the very end, we're looking at their block. So we're looking at how well they can essentially basically spring off that front leg. So you want to see a really solid front leg. You do not want to see them. So kind of opposite what we look for like in a drop jump or something like that mechanics. We do not want to see the hip and knee drop into flexion. We do not want to see them absorb force in that front leg. We want to see them stiffen that front leg to basically propel force upward.
Oh,
So
interesting.
you're
Okay.
looking for, yeah, so you're looking for a negative shin angle, and you're looking for, as soon as they accept weight into that front leg, you do not want to see the knee joint flexion increase at all. So yeah, those are kind of broadly the big things that we look for. And then there's obviously like data points and numbers that we can compare to like MLB averages and stuff like that to see more from a objective standpoint where guys are. But just qualitatively, if you're looking at a pitcher, those are the things that you want to assess.
Sure. So I'll see if I can give people a couple bits of information because it's obvious that you've done this a lot. So if someone is having difficulty, I'll kind of work my way up, ask a few questions, and then we'll keep cruising. If someone is having a hard time and they have a propensity to being on the heel,
Okay.
what are we looking at? And maybe it doesn't have a simple answer. What are we looking at as far as why they preferentially choose to be in that position?
A couple things. Sometimes it's really simple and it's just a lack of stability. So when they get that knee all the way up into peak knee height, they don't have the stability to hold themselves there before they start to sit and stride down the mound. And so they rock back on their heel and kind of posteriorly rotate their pelvis and push their pelvis forward. And that's just like a very passive. So same thing that we see like with kids. If anyone works in pediatrics, when you see kids that have really low tone, we see them like jut their hips forward. They're hanging out on their anterior hip ligaments. They're creating passive stability because they don't have a lot of active stability. It's the same thing in pitchers. If you see them hang out on their heel and they kind of drop their hips forward into that position, they're creating a lot of passive stability and not a lot of active stability. So sometimes it's as simple as just working on drills to get them stable into a knee lift. So get them to lift their knee without a huge change in either their stance knee angle or their hip angle. So sometimes it's just a stability and strength issue. Sometimes it's just a preference of how they wind up. So if they're really trying to create a lot of counter rotation and they're really trying to like get their hip away from home base before they sit and stride down, they're going to run out of room somewhere and they're going to end up dropping backwards. So sometimes it's just a motor control, like we have to teach them, like that's actually not benefiting them, but it's a strategy that in their mind that they've created to just get as much room as possible before they counter move towards home plate. So sometimes it's a strategy issue, sometimes it's a strength and stability issue.
Got it. And do you find that, I mean, I'm sure we could probably classify that as the reason they have all their issues. Like if they're not getting good abduction and extension, it's probably the same of a motor control or a strength issue. Or am I wrong? Yep, please.
No, for sure. Sometimes it's a strength and motor control issue. When I kind of mentioned earlier, like I would never tell an NFL athlete that they're weak. I generally find that's true. PTs, we love to tell people that they're weak. We're like, oh, you just have
They
weak
do.
this or weak that. So often in my practice, so we use dynamometry to test athletes' strength. I almost never find absolute weakness, especially an athlete who's, competing. They just have these little nagging issues. Obviously, they have post-surgical, there's going to be strength issues, but it's almost never an absolute strength issue. It's usually the ability to activate in certain ranges or an ability to coordinate certain muscle groups together, or like just the motor control to work within a certain sequence. So generally, if you isolate a muscle, it's not weak, but do they know how to activate and use it in the way that you want them to? That's generally the issue.
Sure.
So especially with that, that back leg rotation that you're talking about, it's not usually that a pitcher's glutes are weak, but it's that from a motor control standpoint, they don't understand how to use them rotationally, and they're
Mm,
very linear. So they're getting a big push off the mound, they're almost jumping out of the mound. They're not rotating out of the mound. So a big thing that
mm,
we'll see there is they'll drop their knee into internal rotation when they're about to rotate, but their foot is flat on the ground and their toes are still facing forward essentially. So they never kind of like let their heel roll off with them. So I mean, if you did the same thing, if you stood in a wide leg stance and then dropped your back knee in towards the ground but kept your toes flat on the ground facing forward, you're not going to get a lot of push. But if you dropped your knee towards the ground, internally rotated, and then almost like you're smushing a bug, toes in the ground, heel off with you, you can push in that position. The other position you can't push in. So it's kind of that simple biomechanics of, because of the position that you set yourself up to move in, foot planted in the ground, toes facing forward, heel does not swivel with you. It's maybe not that your glutes are weak, but you're not getting a strong push.
mm.
But if we teach you to like really let that heel come up and really rotate with power, now you can actually use the strength that you have.
Cool. Excellent. And so my last question, do you find that with the arm, because like you said, the arm should rotate on the same axis as the torso during the delivery. Are you
Yeah.
finding that people are lacking thoracic extension and they're trying to compensate with getting the arm further back to get more of like a stretch response for the pitch delivery? Or like what would cause changes between like the arm and the torso with throwing?
Great question. Yes, sometimes it can be an issue with thoracic extension. So sometimes they compensate. A lot of times it's because they are not creating enough power with their lower half. So
Mm,
they have to like pull really hard with their arm essentially. So they're relying more on arm strength than they are on transferring energy. And so the more they try and like basically be super active in their arm, sometimes they pull into different ranges of motion. So at
mhm.
that point, you're seeing them not necessarily transfer energy, but try and create their own. And that's where it can kind of create funky arm paths.
Sure.
Sometimes it's a coaching issue. Coaches have told them to, for example, like if they want to get more spin behind the ball, they need to be more behind the ball. They're trying to get them to be a little bit more over the top to pull down on the ball. But sometimes instead of like keeping everything together and getting more over the top this way, sometimes pitchers just do this.
Mm.
So sometimes it's a coaching issue. Sometimes it's, like I said before, sometimes it's a motor control issue. They aren't transferring energy well, and so they're trying to create more energy within the delivery.
Sure, like they're trying to muscle through it with their shoulder
Yeah,
and their upper body
exactly.
as opposed to generating the force and being able to efficiently carry it up to the arm.
Yep,
Okay,
exactly.
got it. Got it. So when you get one of these people on the table and you've looked at them, you've watched some deliveries, some throws, or for anyone else listening, some swings, some pickleball swings, whatever.
Mhm.
What are you looking for as far as when you're talking to them, the subjective portion is going to cue you in on what you really need to address? And maybe I'll preface that with a different question. Like, are there kind of these primary buckets where you're like, someone's coming to you with a shoulder injury, they do throw, either they pitch or they play baseball at a high level and they're dealing with an upper extremity issue? Are there these kind of categories where you're like, well, they're dealing with X, Y, or Z, and then you're going to, through your evaluation, kind of put them in that bucket? Or do you find that that's not the case?
Ooh, that's a good question. With the shoulder, it's really interesting because there is, the buckets we could kind of create are like, are you getting some sort of, primary, secondary impingement? Is it a
Okay.
labral issue? Is it a rotator cuff issue? Is it kind of like a scapular strength and stability issue? It's so messy in the shoulder because all those kind of do this.
Right.
So even
Right.
with the test measures that we have to kind of isolate out, is it the labrum? Is it a rotator cuff? You're going to get positives for almost, like, let's say you have an acute labral tear.
Sure.
Your rotator cuff manual muscle tests are going to come out positive.
Of
There
course.
might not be anything wrong with the rotator cuff. Your
Sure.
labrum tests are going to come out positive. Some of your impingement tests are going to come out positive. Like
Mhm.
it's so messy. So at that point, you really have to take into account sometimes the age of the athlete, right? So if it's a
Okay.
60-year-old pickleball player, I'm leaning way more towards your rotator cuff is probably an issue because you probably had degeneration before this. You probably weren't very strong. Your rotator cuff is generally going to go from a repetitive standpoint before your labrum does.
Okay.
If it's a younger pitcher who I'm expecting his rotator cuff to be strong, I'm leaning more towards labrum. If it's a football player and it's contact, just based on mechanism, I'm going to lean more towards labrum.
Got it.
Um, and then sometimes you just need to look at how symptomatic they are and how positive your tests are and what their function is. And then you just get to say, something is wrong here.
Sure.
Something's probably foreign. Is it your rotator cuff? Is it your labrum? My tests are kind of saying it could be either. I'm just sending you out for imaging regardless. So that happened to me this last season. I had one of my quarterbacks took really hard impact
Mhm.
and everything was positive.
Sure.
And and it was one of those where I literally tell him it's either your labrum or your rotator cuff, maybe both, but it's something you need to go get imaging. Um, and so sometimes you just need to get close enough to say that they're a candidate for imaging. And if, like I said, if it's not as severe and you don't think they're a candidate for imaging and you think regardless this is probably rehabable conservatively, then we're taking into account more so demographics because we do know that certain demographics lend themselves more commonly to different injuries.
Sure. So I'd like to break that down a few ways. So is there anything that the patient is saying that cues you in instinctively that you're thinking more? Because obviously demographics is a big one. Is there anything that they're saying as far as what they were doing, especially from the athletic population? I think it's easy to understand that if someone, because a lot of people over 40 and even younger are suddenly getting into pickleball when they have not been athletic for
Yeah.
most of their life, it's like their body is underprepared and suddenly they're playing 10 hours a week of pickleball. It would make
Yeah.
sense that that would lend towards a rotator cuff, tendinopathy, tear, other issue before it actually damages the structural integrity of the labrum. That makes
Yeah.
sense to me. But for the younger people like ourselves, people who are younger than us, um, are there cues about where it hurts, when it hurts, um, symptoms down the arm, into the shoulder blade? Like, is there anything that they're saying that kind of cues you in on what you need to look at?
Yes. For the labrum, it's generally like specific motions, super sharp and painful, and I get out of that and I'm fine.
Okay.
If it's when I reach across my body, oh my God, it's so sharp. But I can basically do anything else.
Okay.
Um, Rotator cuff tends to be a lot of stiffness in the morning, especially in the older population. And a really common thing you hear is like, when I have to like reach up.
Hmm.
Because as we know, your rotator cuff is providing stability, it's pulling that humerus into your glenoid. So it's the reaching up and that in the initiation of that movement. So people are having issues with the initiation of a reach, more so rotator cuff. Global stiffness tends to be more rotator cuff. I'm trying to think of other kind of cues people give me. Labrum is sleeping on their shoulder at night. I cannot sleep. So anything that provides like compression into the joint, if that is bothering you, it tends to be labrum. um, in my experience. Also, caveat, like I said, sometimes your patients are just made to trick you and they're going to give you these verbal cues and it's not any of that. So nothing falls perfectly into the bucket, but I would say those are my biggest ones. If it's a singular, like a point in a range of motion that people have really sharp pain, but then are kind of asymptomatic outside of that range of motion, more so labrum, stiffness, pain with initiation of movement, rotator cuff, laying on the shoulder at night, pain tends to be labrum.
Okay. And a third kind of classification you said is maybe scapular strength and stability. What
Yes.
are those people going to sound like when they're coming in?
So those people are almost more similar to the type of complaints you get with someone who has kind of like idiopathic low back pain. And it's that kind of combination instability. So it's like any position for a long period of time bothers them. Changing positions bothers them. Like it's just kind of like it doesn't follow like a certain pattern.
Mhm.
Same thing with the scapular stuff is it's tends to be more idiopathic. They don't have a mechanism of injury. And it'll end up a lot of times looking more uh, like an impingement because as we know when the scapula isn't strong, it's not in the right positions, your shoulder joint ends up being not in a very good position. A lot of times you get that, especially that posterior impingement can be
Yeah.
because of scapular positioning. So those ones are they don't really follow a pattern. There's a lot of different motions and things that hurt them. A lot of times there's an endurance component of it. So like, for example, a volleyball player, by the end of practice, when I swing, I get a lot of pain or, all that kind of stuff. So less pattern, more endurance based, that kind of stuff.
Got it. So we're looking labrum, kind of like, ow, in this sudden position, sharp pain, sucks, otherwise quite normal. And
Yeah.
especially sleeping on the shoulder. People that are like, oh my gosh, I sleep on that shoulder and I just wake up in a lot of pain. Rotator cuff, we're thinking from your perspective, more achiness in the morning, difficulty initiating movements, or like, oh, I suddenly go to reach and I get a little twinge. Positions that would require greater stability of the shoulder muscularly. So initiation, elevation, maybe these kind of funky positions back here, and
Yep.
then scapular stability and control and strength. You're thinking more, oh, by the end of the practice, my shoulder kind of hurts more and more as I go along because they either lack endurance and stability. And so over the course of using something repeatedly, it starts to feel worse.
Yeah. And those are the ones too that you do all your special tests, you're not really going to find much.
Got it. So yeah, going into the testing portion, like kind of run me through, someone has a shoulder injury, kind of run me through your order of operations in the clinic.
Um, so if I'm not doing some sort of biomechanical evaluation, I'm just, having them on the table and doing my more typical PT eval.
Mhm.
Probably the first thing I do is all your midline testing. So in that comfortable shoulder open pack position, we're going to test internal, external abduction, flexion, extension.
Okay.
That kind of gives you your first clue of the joint space itself is not being stressed at all. If they have pain in that position, it's going to lend you more towards something muscular, rotator cuff. Then I start to move just from right there because they're already in that seated position. I pretty much test everything that I can seated. So I'm doing biceps long head test. I'm doing empty can full can test. I'm doing 90-90 posterior impingement test, and I'll test strength up here too. And then I'm going bear hug across for that posterior rotator cuff. We're going your internal rotators off the back, lift op test. What do I move into from there? Then I lay them down. We're doing instability test. I'm doing
Mhm.
biceps load test. I'll do my crank test at 90 and then at 120. Um, and yeah, I think that's, and my Thomas test or Tyler test across.
Okay, perfect. So a couple questions. So when you do manual muscle testing or strength testing, you don't just have them by their side. You preferentially put them into this kind of open packed, like flexion, abduction, kind of up here position when you do all those tests.
Yeah.
Okay, just because I
So
know a
yeah,
lot of.
sorry. I'll do it at midline and then we'll
Oh,
put them in
okay.
an open back position, see if there's any difference.
For all of those internal, external, flexion, abduction, extension.
Yeah.
If there is a difference, what does that tell you?
So if they are stronger and more comfortable in an open pack position, I'm starting to think joint space might be an issue for them.
Okay, meaning that they have some type of inflammation or impingement.
Yep.
Okay, got it. And then,
Potentially, as you know, you have to combine
sure,
the results of every test, right? Like if we can't just rely on one thing. Go
sure,
their
absolutely.
back is better. It's something intra-articular. Maybe not. It might just be a length tension issue with their rotator cuff. They're more comfortable in that position. So you got to look at the whole picture from all those tests and then make a decision.
Got it. So once you do that, you've kind of assessed. Are you commonly finding that? Because, like you said, you have to take the whole picture into consideration, and that's why people are like, you can't trust special tests. It's like, well, you can if they're in a big enough cluster. It can give you a
Right.
treatment direction.
Right.
So we kind of are three diagnoses of labral irritation or injury, rotator cuff pathology of some kind, and scapular instability, poor motor control. It's like, what are you commonly finding looking at those that seem to line up consistently that tell you it's a labrum or that you should start with interventions? Well, I'll jump ahead. Does it matter? Because I think a lot of people are like, it doesn't even matter if it's a rotator cuff or a labrum or a scapular stability control issue. I'm going to start at the exact same point. Do you find that's true for you or not?
Um, I, to an extent, do find that that's true. And this is, again, the athlete that I'm talking about, where I was like, might be your labor, might be a rotator cuff. Everything is popping positive. Um, what I told him and what I tell all my athletes is, it doesn't really matter. We're going to treat it the same.
Fair enough.
Um,
Great.
yeah. So, because what are you going to do? Either way, you're going to strengthen their rotator cuff.
Hmm.
Either the way, you're going to work on the motor control between their scapula and their humerus.
Great.
Either way, you're going to work on if they're, like I said, when we integrate back to sports, we're going to work on the motor control of coordinating your core, your scapula, your rotator cuff, your sequencing of movement, getting good stability posteriorly. Like either way, we're going to strengthen around the shoulder. We're going to make sure that we're not in a position of impingement, and we're going to make sure you have a stable base, no matter what.
Yeah.
Especially,
Right.
really, the only thing that changes, and not even very drastically, between labral repair and rotator cuff is surgical protocol. So if they are
Mhm.
injured enough that they're going to get surgery, some of those things are going to change a little bit. So, for example, if they have a full rotator cuff repair, they are not moving that thing. They are so immobilized.
Sure.
And we're really not starting to activate the rotator cuff for some time. If it's a labral repair, I'm starting on rotator cuff isometrics day one. And
Hmm.
they have a little bit more leeway to get some early movement than if they have a full rotator cuff repair. So there's some kind of protocol things that are going to be different depending on what surgical repair they have.
Hmm.
But if they are a non-surgical conservative rehab candidate, you don't have to nail the diagnosis all the time. I know people in PT school are going to rail against me on this because we're so heavy on like get the right diagnosis. But the truth is you're going to treat it the same. So you can
Okay.
take some pressure off yourself of if you don't nail it, you can still make them better. You know what I mean?
Sure.
But if I'm treating for impingement, but it's really a labrum issue, like I'm still treating the labrum issue, truly.
Right.
So
No, I agree. And I think that's what's hard in a lot of PTs. They get to situations like this and they just feel like a failure. Because it's like in PT school, they're like, you have to be able to know what it is. And it's like some things you do, other things you don't. And I agree. I have found that with shoulders, as much as I would like to know or feel like I'm leaning more this way in my mind,
yeah,
clinically, it really doesn't matter. Like
yeah,
you're gonna address the same issues regardless, because again, the body's a system, needs to function optimally. And that doesn't
yeah,
mean it's the same across people, but you're really looking at the same thing. So intervention wise, let's do manual first, because I've seen that you do a lot of manual interventions. I've seen you do cups, I've seen you do scraping, I've seen you do hands-on, soft tissue,
yeah,
joint mobilization. What are kind of your go-tos? And of course you can put whatever qualifications you'd like for manual interventions to the shoulder area.
yeah. Um, I would just want to quick caveat this because I get asked this all the time of like, are you a believer in manual therapy? What do you think is better, Therax or manual therapy? When do you do both? When do you do one? I find that you're gonna have issues if you land on one end of the spectrum or the other.
Oh, of
If you are
course.
only doing manual therapy, like your patients are really never gonna, they might feel better, they're never really
Hmm.
gonna get better. If you're
Right.
only doing Therax, you may not be able to fix some of the, like, you may not be able to get your patients into a position where they can then do the exercise the way you want them to. You also, I have a dog too, no worries. You also may not um, be able to get the athlete buy-in because an athlete's coming to you and they want to feel better today. And there's no exercise that you have in your repertoire that's going to make them feel better today. So you have to be able to use both, especially if someone's post-surgical, like they're going to have range of motion issues, they're going to have soft tissue restrictions. There's no exercises that are going to solve those the way your manual therapy is going to solve those. So my big go-tos, and of course this depends on the situation, the exact diagnosis, where they're at in their recovery process and their rehab process. But um, I do, when it comes to soft tissue, I'm a big believer in trigger point release, and I do a lot of fascial manipulation, and then obviously just like your typical soft tissue. But something I always tell my patient, or my not my patients, my students, when I take clinical students from PT school, is you should be such an expert with your hands, and this takes time. But when you feel a muscle, when you feel soft tissue, you know kind of what's going on. Like, is this just a tight muscle? Are there trigger points? Is there fascial adhesions? Like, and so I tell students, like, you kind of need to be able to feel the difference between like a string in the muscle fiber nodules in the muscle fiber, something that feels gritty or almost kind of crunchy, or something that just has higher tone, because it's going to
Mhm.
change the way you do soft tissue, right? So I think so many PTs want to get away from soft tissue because they don't want to be mistaken for, or they really don't want to be in the same club as like massage therapists. But I
Mhm.
think we need to set our ego aside and realize like we can really be experts with our hand and really fine tune, and not just, quote unquote massage, but we can really figure out like what is the issue with the soft tissue, and then address that directly. So am I scraping? Am I doing ART? Am I doing deep pressure? Am I like, depending on what I feel on that soft tissue is going to change the way I do soft tissue. So we can really be experts in that field, or we can just get in there and get in our elbow and just do soft tissue. So if you're doing the latter, yeah, you're like a massage therapist. If you're doing the former, you are now a diagnostician and a doctor of physical therapy. So I do a lot of soft tissue. I do a lot of joint mobilization and manipulation.
Can I
I,
interrupt you real quick, Emily?
yeah,
So, I often find in these conversations, I have the people like, oh, I just do like your typical like fascial release. I have found most people don't know what that means. They don't know what it means. They don't know how to do it. They don't know what the heck it is. You had really brought up four things. You
yeah,
had brought up trigger point, uh, active release techniques, ART, trigger point release, myofascial manipulation or fascial release. Would you describe just briefly what that is and how you like to do it?
yes. So fascial manipulation, there's is basically the treatment philosophy where we look at each joint in the body and the
Hmm.
directions of movement. So, anterior, posterior, internal, external, medial, lateral. Like it's basically 6 different planes of movement that happen in each joint. And even if that joint, like your elbow, for example, doesn't have like medial, lateral, really, it still attenuates force medially and laterally.
Sure.
So there's different points. There's basically one of those 6 points at each joint where force in that direction tends to get attenuated through the fascia. And so because force tends to get attenuated in that direction, in that place in the fascia, that's where the fascia tends to get stuck. So you're kind of testing those 6 points, and you will feel like it literally feels like a kind of a crunch underneath your finger when you get to that point, and it's going to be most tender for the patient. So you kind of find which direction of movement is most bogged up at the joint or the area where you're having problems. And then you kind of test up and down the chain. So let's say it's an elbow. I'm going to test those 6 points. Let's say I find the anterior point to be most troublesome. Now I'm going to go below to the wrist and above to the shoulder, and test the anterior points and see which ones are stuck. So then you kind of go up to the whole chain, and you basically you release that line. And
Okay, so
essentially the way you do it.
you're working off of fascial train models.
Yep.
Okay,
And
got
then
it.
from a technique standpoint, again, the way I was trained is I jokingly kind of call it the noogie, but it's basically you get in there with like your elbow or finger, and you're cross frictioning that point because you're trying to create heat under your finger, because there's essentially a chemical process that happens. So, our layers go skin, fascia, muscle, and the kind of lubricant between those layers is hyaluronic acid. When you have inflammation in an area, it creates a chemical reaction because inflammation is full of chemical mediators that essentially takes that hyaluronic acid, which is normally like a foamy soap consistency, and makes it like sticky like molasses. And heat creates a chemical reaction that makes that sticky molasses hyaluronic acid kind of back into that foamy soap consistency.
Hmm.
So you're trying to basically like create that heat, create that friction that's going to allow your fascia to kind of move and glide again well in that space.
Okay,
Um, so it's basically an aggressive noogie, and then you're evaluating based on those planes of motion. So kind of
okay,
an anatomy planes kind of treatment philosophy.
got it.
Things like cupping and scraping also
Hmm.
address fascia. Um, there's some argument as to how well, but those address fascia too, and I do both of those things as well. Those are kind of, I would say, like more broad stroke techniques, whereas the fascial manipulation is a little bit more specific.
Sure. And as far as how long you're doing that little noogie, is it like if I'm doing it less than this, I don't think I'm doing anything. If I do it more than this, I've obviously overcooked this person. Like,
Yeah, it is really all based on what you feel underneath your fingers, and
okay,
when you feel that kind of crunchiness break up. So you'll feel it get smooth. And generally the patient will feel too like it's almost unbearable. It's really, really painful. And then like, oh, it's not as tender
not
anymore.
bad.
Yeah, so it's kind of like you should feel it under your fingers. You should feel it kind of smooth out a little bit, but your patient should also feel the difference.
Got it. Okay. So, anyways, you were talking about kind of the manual interventions, cupping and scraping. I will ask this. It seems like a good time. Does the amount of manual that you do in season vary from the amount of manual you do out of season? Although
Oh,
I know it will depend on the athlete. I know that's true.
yeah.
Are you finding though that you're doing more of one, like more manual versus Therex in season versus out of season?
Yeah, great question. Way more in season than out of season.
Okay.
So, and something I try and get either my students that are with me or other PTs to understand when an athlete is in season, by the time they come to see you, they, especially let's take the NFL for example, their days start at 6 or 7 a.m. They're done at 5. So my first appointment usually is around 5:30 p.m. for the NFL guys. And they've had a lift, they've had a walkthrough, they've had a 2-hour practice, and then sometimes they're doing like corrective stuff in the training room alone. By the time they get to you, they are cooked. If you have an hour-long Therax program waiting for them, they're not coming back to you.
Right.
Um, and so a lot of times what we are doing is it's way more manual based because we're just trying to get them to the next practice to the next game. So the treatment philosophy ends up being not just what's that hour that I have with them during season, but again, these guys that I have long term, we are trying to build up all of their strength in the off season. We're trying to create really good programs that set their bodies up well. And then we have maintenance stuff that they do through the season. So when they come to see me for that hour, we're doing recovery stuff. We're doing joint mobilization. We're doing all the manual for that hour to get their body to feel as good as possible. But they have a maintenance program that they are doing outside of that hour with me. So they either come an hour before they see me on the table or they stay a little bit longer to do stuff. Or when they're at the team facility right before practice, they have a little routine that they're going through. So it's not that I'm not prescribing exercise, but at that point in time, like I'm giving them like, hey, here's your activation routine that you need to do before practice. Okay, you had a midfoot sprain today. So I'm going to give you these, I'm going to show you these 4 exercises and it's on you to do them. And then you're going to get the whole hour to feel better. And that's I find that that's really important during the season. So it's not that Therax isn't a part of it, but you have to be really strategic about how you plan it. And I think for the most part, every time I've experienced this, like athletes are people are always worried about, oh, my patient's not compliant, they don't do their home exercise program. A professional athlete's gonna do their home exercise program because it's make or break for them. So I have
Right.
never prescribed a home exercise program for a home exercise. It usually ends up being at the team facility exercise program that athlete hasn't done. And like I said, my guys who are with me year round, they have routines. Like we know, hey, ankle mobility is an issue for you, and ankle strength has been an issue for you. So you have like a maintenance kind of ankle program that you do every Wednesday. Um, so yeah, all that to be said, way more manual during season, and then in the off season, it's much more strength and conditioning training based.
Sure. So for anyone listening, because we try to get into the nuances, but there are so many topics that on their own could be multiple hour-long conversations. Like the skinny of it is if you want to work with the highest performing like athletes, you're gonna have to do more than Therex because they already get the crap beat out of them in practice and by their trainers and by
Yeah.
all these other people who are generally highly competent in some amount of exercise. It's like so being able to use your hands, being able to detect fascial and muscular changes, and being able to analyze how those would impact how they move is really going to set you apart. And that will simply have to be something for another day, or you're going to have to look at stuff on your own because that's outside the scope of time that we have today for the topic we want to cover. So exercise wise, Emily, let's do the shoulder. I know we're coming up on an hour. Um, where is your ground zero? And let's put it into 3 categories because obviously like people should be able to progress and regress. Like that's kind of their job. Where
Yep.
is your ground zero for a highly irritable shoulder, a moderately irritable shoulder, and a low irritability shoulder that is coming to you with issues?
So what exactly do you mean by ground zero?
Oh, sorry, meaning exercise intervention wise. What do you
Okay.
like to start people with if they're coming with shoulder pain and they're highly irritable? And intervention wise, if they're moderately irritable, which I assume is just a step or two up from the other people. And then if they're low irritability, like where are you kind of starting these people? Since, like we said, a lot of the goals, regardless of diagnosis at the shoulder, are in the same direction.
Yeah. For sure. So for my highly irritable shoulders, I'm a big fan of isometrics,
Okay.
especially because highly irritable, you're going to start to get some like pain avoidance behaviors too. And I
Mhm.
find that those low level, kind of longer timed holds, one, from a neurologic perspective, kind of teach the brain like it's okay to activate the shoulder. This is totally safe. From a
Sure.
patient's perspective, they're not moving their shoulder, so they're not anxious or worried about it.
Mhm.
And it just, even that activation can help basically mediate pain in the brain to then prime them for some like maybe lower level movements at that point. So that's my highly irritable shoulder. I am starting with isometrics. And as they get comfortable with isometrics, sometimes we don't even move into like, active range of motion, but we just might move out of mid range. And now eventually by the end of the session, I'm having them do isometrics at end range,
Hmm.
which then when they go to move their shoulder, as I'm sure you've seen too, like if you spend some time doing isometrics at end range, any joint, the amount of more pain-free movement you're going to get just being able to activate throughout the range of motion, it's amazing. So
It
that's
is.
where I would start my highly irritable people. My moderately irritable people, I'm going to start with strength training away from the shoulder. So I'm going to
Mhm.
start with some scapular stuff. I'm going to start with some core stuff. I'm going to start basically priming them to integrate the shoulder into movement without directly strengthening, like isolating the shoulder out. So that might look like, some like PNF patterning. That might look like some like rotational core stuff that's getting them to like work, like move with their scapula, but they're not doing like isolated shoulder movements. And then for my low irritability people, we're going right into higher level strengthening. So I'm going to figure out what ranges and what torque kind of loads are bothering them. We're going to stay out of those, but we're going to jump right into, again, more integrated movements, but like actually loading the shoulder. I try not to do like just shoulder specific, like isolated strengthening, because I just don't think that that's very functional.
Sure.
And especially when you have irritability, the more you can integrate scapular movement, the more you can integrate thoracic movement. I think one, the more specific and transferable, but two, the more protected your shoulder is going to be.
Sure. So, a couple questions. So, your isometrics, I have generally found, or at least the clinic I'm at, I often use 10 of 10 seconds. And it's fine. I've done 5 of 20, I've done 5 of 30, I've done other numbers. What do you generally like to dose your isometrics as?
Sometimes I do kind of the PRI method, which is about 7 seconds on, 20 seconds off for 5 rounds.
What is
Um,
PRI?
Postural Restoration Institute.
Okay, got it. Got it. Just so
So
people
it's
know.
yeah. And then sometimes I can't remember the researcher's name, but he did research on essentially like tendonitis and tendinopathy.
Mhm.
And he found that longer holds, so 20 seconds on,
Mhm.
10 seconds off, was really helpful for tendon injuries. So again, depending on what exactly the injury is, if I think there's tendon involvement, sometimes I'll go for those like 10% of your effort, but holding longer.
Mhm.
If they're a little bit more irritable, and I think it's more of a muscle belly issue, I'll kind of go more so for the 7 on, 20 off.
Okay. Are you talking about Keith Barr from UC Davis?
Yes, yes, I am.
Okay.
Thank you.
I know a thing or
Yes,
two. There's things up here.
yes.
Okay, so the big question is that people really want to know about the shoulder is a couple of things. How do you know when they can throw how hard? Like when can they start throwing again? Like what are you looking at? Like are you looking at a certain series of exercises that are loaded, or are you having them just simply throw with progressively higher intent? Like, how are you determining that shoulder is ready to go back to either certain types of throwing or full throwing again?
Yeah. So your super base things are, do they have full pain-free range of motion? Do they have full strength? So ideally you have baseline numbers for these people so you can compare. If not, you can compare to the unaffected side. And then the caveat for throwing is we don't have an exercise that perfectly emulates throwing.
Right.
Like if we're talking about running, like I can test like, can you do a single leg squat? Can you single leg hop? Can you do the same amount of calf raises? Like we have some stuff that like really easily correlates to running. Like can you do
Hmm.
triple extension? Like these are all the components of running. If you can do those, I feel really safe getting you on the treadmill.
Okay.
Throwing, really don't have exercises that, in my opinion, like correlate as well to throwing. So what I'm looking for is full strength, full range. And then we do a lot of 90-90 strengthening with throwers.
Hmm.
If they can get their full range of motion in 90-90 under like a pretty heavy load, I feel safe getting them to throw. And here's the thing with any return to play decisions, you're looking at breaking down the movement. Can they do the components of that movement pain free? Um, and then tissue healing timelines. Once you've checked those two boxes, there is a little bit of trial and error. Okay,
Mhm.
you've checked all my component boxes, and now we just have to get out and toss. And does it feel okay? If it didn't feel okay, we're not ready yet. Okay, felt okay tossing, like let's keep going. So, and that's at that point, you have to let pain be your guide. Sometimes you just have to say, like, from a tissue healing standpoint, I know you're good. From a strength and range standpoint, I know you're good. I can break down the components of the movement that you need to do. So, can you stabilize and work concentrically and eccentrically? Sorry, that's my dog. At 90-90. And then can you coordinate your scapula to support your shoulder through its full range of motion? So we're looking at like heavy loaded PNF patterning stuff. We're looking at, can they do med ball throws? Are they ballistic in those positions? All that kind of stuff. And then you just have to take that lead and say, we're going to start with some easy toss. If it hurts, I know you're not ready.
Okay, so if I recapped it, and I'm glad you brought in some specific examples because people are always like, "What do I do? Like, I need an end goal." So if I
Yeah.
were to, so you're looking at heavily loaded kind of PNF
Mm-hmm.
as an option. You're looking at what the body should do, what the different joints should do, and if they can do that effectively. When you talk about can they handle loaded 90-90 pretty heavily,
Mm-hmm.
what positions are you in? Are you like taking a TheraBand or some type of resistance band and getting them up there and going into like internal and external rotation? Are you doing like ball drops in 90-90 positions? Are you doing like throws in 90-90 positions? Like, how are you testing that 90-90 position for strength?
Yeah. So we can test it with dynamometry right here, like isometrically,
Oh,
like,
okay.
or you can test it isokinetically in this position too.
Okay.
But from a exercise standpoint, a couple different things. Sometimes I do manual or resisted. So isometric, can you hold and stabilize right here? Sometimes I do manual resisted, concentric, eccentric right here. We can do like TheraBand or J-band routines where they're working 90-90. Can they do that in both directions, both
Mm-hmm.
concentrically and eccentrically? And then, like you said, there's like weighted ball stuff you can do here where they're dropping and throwing back. So a little bit of everything, to be honest.
Sure. Well, and ultimately, like the goal is not end all be all. Like, oh, Emily told me how to like now my life, like all my problems are solved. Like, we
Yes.
just want to give people some ideas because most people they just feel lost. Um,
Yeah.
so let's kind of. I would like to talk lower quarter just for about 10 minutes, and we're gonna kind
Yeah.
of skip over the assessment portion because ultimately, a lot of lower extremity testing is the same range of motion, strength of the joints in different positions. I will ask one question in particular, and then we'll jump to the kind of how do you transition from rehab to return to sport for lower quarter. Um, what are you looking at in the initial eval if someone has not had surgery that I may not look for in just a standard person with knee pain? You had brought up maybe some single leg hopping, different movement like patterns. What are you looking at, especially for your NFL guys with lower extremity issues in that first session that is outside of just range of motion and strength that other people could implement?
Um, Honestly, I think it comes back to movement. Sometimes, especially in pro sports and with the NFL, they have game film. So if
Mm-hmm.
it's something idiopathic, I can just generally look at game film and look at what their movements in general look like. And sometimes if they have a mechanism, I can look at the actual play where they
Sure.
got injured.
Okay.
So one would be film and their actual movements. Um, the other thing, I mean, outside of those things, I don't know if I'm looking at really anything that's crazy unique to your
Sure.
typical ortho PT, to be honest.
Sure. Well, and I think the reason a lot of orthos do like single leg hop tests and calf raise and like this, that, and the other is because they don't have access to what you have. Like you
Right.
can
Right.
watch, you can see, you have lots and lots of hours of recorded footage. So a lot of people that are asking me, like with the lower extremity, like how do you like to progress people to running and then multi-directional movements, including plyometrics? Because at a certain
Mhm.
point, you can only do Bulgarians, lunges, like barbell back squats. Like you can only do those so much. Like,
Yeah.
what are you looking for as far as your objective measures? Because we all know that if we had good ones, this wouldn't be a question. Um,
Yeah. Yeah.
what are kind of your objective, according to Emily, like metrics you're looking for when you're progressing people back to running, multi-directional, and plyometric type things?
Okay, so my general roadmap for Therex starts with isometric,
Mm-hmm.
dynamic,
Okay.
ballistic. And then with each of those, you start
Sure.
double leg, then you single leg. So isometrically, can they stabilize throughout their full range of motion? Can they hold max torque?
Okay.
Dynamically, now you're looking at simple things like squats, lunges. Can they move through their range of motion with strength, evenly side to side?
Mm-hmm.
Great. Once they've done that, now you're moving into ballistics. So when you get into ballistics, we're starting single plane ballistics. So let's say jumping, you're gonna start double leg jumping.
Mm-hmm.
When you start double leg jumping, we generally do the concentric portion first, leave the eccentric portion for later. So we would do jump up before we would do jump down type of things.
So like box jumps on, step down.
Yeah, exactly. Exactly.
Okay.
And then once you're confident in both their double leg, concentric, and eccentric phase of a plyometric, now we move to single leg in one plane of motion. And then when you are ready to go multi-plane of motion, you go back to double leg. And you start with the concentric phase first, and then you move to the eccentric phase. Once you do that, you go back to single leg. Start with the concentric phase, move to the eccentric phase.
Okay.
So that's my general kind of like roadmap that I'm the order of things that I'm doing. Now, as far as when you know that somebody is ready for those things, again, one, it comes down to all the same things. Initially, strength, range of motion, tissue healing timelines. Like we know how long it takes generally um, a tendon to heal. We know how long it takes a ligament to heal. We know how long it takes a grade 2 muscle strain versus a grade 3 muscle strain. All these kinds
Mm-hmm.
of things. And then as far as when you're kind of building out that routine of what exercise, we know we talked a little bit about reverse engineering. So you know what the end goal is movement wise for an athlete. Now you need to break that movement down into phases. So what strength do they need? What range of motion do they need? What movement pattern do they need? So the super easy one, for example, would be running, right? Like we have our loading response phase, and then we have our triple extension kind of acceleration phase.
Mm-hmm.
So if I'm going to break down loading response, they need to be able to basically do a single leg squat. If I'm breaking down the triple extension phase, I'm going to, build out triple extension based exercises. So
Mm-hmm.
maybe I'm doing like a Bulgarian split squat type position and having them work triple extension forward. Sometimes I'm putting them in a step up position with a bar on their back and they're triple extending forward. So, you're breaking down what does the movement pattern look like. I'm building exercises based on that movement pattern. And I think if you just make it that simple, what's my end goal? What are the phases of that movement? What are the movement patterns and strengths that are needed to perform that phase of that movement?
Sure. So, okay. For anyone listening, that was a lot. I will, right after we're done recording this, I will try to recap it so that we
Okay.
don't take too much of Emily's time. Okay, great. So as far as this leads into one of my kind of final questions on the rehab side, because a lot of people see all these awesome videos. Do you know Dr. Reef?
Yeah.
Uh, okay, yeah. So
Well,
Dr. Reef, he works
not
with a lot of
personally, but know
yeah,
who
but
that
you've
is.
you've heard of him. You've seen him on the
Yeah.
Instagram
Yeah.
world.
Yeah. Yeah.
A lot of people kind of see the stuff that they're doing, and it's like Alvin Kamara's standing blindfolded on a Swiss ball, and all these people are in these crazy positions. And
Yeah.
people are really curious, like, does rehab and the transition between rehab to performance, does it have to be that complex? And I'm sure the answer is obviously no, but like it obviously can't just be strength training, like some people would say. Um, so really, like, what is the boundary like when you look at your more complex activities?
Hmm.
Are like what is kind of the highest end of complex activities that you feel are necessary for these people to get back to normal function without just being overkill?
Hmm. Good question. My short answer is no, it does not have to be that complicated. And also,
Mm-hmm.
you have to think about like specificity. Like, when does what Alvin Kamara does look like standing single leg on a Bosu ball with a blindfold? Like,
Mm-hmm.
this is my soapbox, but I think our profession got really obsessed with the Bosu, and then we just
Mm-hmm.
want to do everything on a Bosu. And like, does that actually correlate to function? Most of the time, no.
Mm-hmm.
Um, Now there's a time and a place to challenge somebody without eyesight with a blindfold. Does that really correlate to return to sport? No, I think what you do when you blindfold somebody is you're creating a very specific adaptation. It needs to have a purpose. We don't just blindfold people to blindfold people. Like, you are trying to drive proprioceptive input or vestibular input. Unless that's actually an issue for somebody, there's no point in blindfolding them. So I would say, yes, a return to sport professional athlete is more complex, but not in a gimmicky way. Not in a, I'm going to
Mhm.
throw somebody on a Bosu ball, balancing on a foam roller, juggling, and then reciting the ABCs. Like,
Sure.
not in that regard, but it
Mhm.
is more complex in the intensity of what they have to do is more complex than the average person. So your exercise needs to gradually progress and look more and more like what they do. So sometimes for me, like at the end of somebody's rehab program, we're on the field, we're doing drills, we're doing sport specific movements. In the gym, we're trying to recreate moments and torques and demand that they'd see on a football field. So, something that comes to mind is I was rehabbing a defensive end from a sports hernia. We call them core injuries now, but people more commonly know them as sports hernias. Well, one of his big needs is to basically like grab an O lineman and be able to rip around them.
Mhm.
I don't have an O lineman in my gym, but I have my body weight, not the same as an O lineman. I can put him in an unstable position, split stance, something where he can generate less power from the ground. And I stood on a slide board with a striking mat, and he had to grab and pull. So we're progressing his core rotational core exercises. So instead of just doing like some Russian twist with a med ball, I made him grab my 135-pound body and pull me from a really weak position to basically stress his core. So it can get more complex in that way. But I would say the more complexity you add, it better be just to look more and more like what their demands of their sport are, and not just these gimmicky things to make things hard for the sake of making things hard, if that makes sense.
Sure. I will say to anyone who has not seen much of Emily's content, number one, you should go check it out. I have found it very insightful. Two, um, I have noticed that you like to use Dynadiscs and balance pads. And I love that, because there is this war from the strength and conditioning side that stability is trash. And of course it is not. It most definitely is not. Um, and so what I would say is, I'll kind of describe this and you can just say if it's true or not. I generally find if I can have a patient and maybe they're in a split squat, I lower them down into that position on the affected side and they try to hang out there, their normal side will be pretty good. And even if you think they're strong, their affected side will be all over the place.
Yes.
And so if you're saying, when should I throw in a Dynadisc or a Bosu or an AirX? It's like probably not until the static position is relatively stable compared to the other side. But it's like they are going to experience circumstances in sport where their foot is going to hit the ground. It will have to perceive what the freak the ground or the person's foot underneath their foot on the ground is doing to prevent them from getting injured. And I think that's a good place to include some stability work on compliant and unstable surfaces.
Absolutely. Like I said, if you just have to have a reason behind it. That's why I say, like, don't make things hard just for the sake of making things hard, because I can
Mhm.
make any pro athlete fail if I just create like an obstacle course of just psychotic craziness. But
Mhm.
yeah, I use, especially for foot and ankle stabilities, like Eric's pads, Dynadiscs all the time, because what
Mhm.
I really like about it is it creates co-contraction.
Mhm.
It's super functional.
Right.
You know what I mean? Does that mean I do every single exercise on one? No, obviously not. But if I know this person has struggled with, for example, I've got somebody right now who's got like a peroneus longus tendinosis.
Mhm.
I'm going to do everything I can to create co-contraction around that ankle. I'm going to do everything I can to create more stability around that ankle. If I have someone with a midfoot sprain, like, of course, there is a time and a place for this that I think would be super valuable. And I think stability is huge. There's a lot of people that have
I agree.
complex pain, and if we can just teach them to stabilize, their pain goes away.
Mhm. Yeah, I agree. So I will end with my final question. And a lot of people are very curious about what type of continuing education you pursue.
Mhm.
Well, I guess it's a two-part question because a lot of people want to know about cortisone injections or steroid injections, and a lot of
Yep.
people want to know what you're doing to keep yourself educated to help these people at the highest level. So feel free to take as long as you need for that, and then
Yeah.
finish up with whatever plug you'd like for yourself, and we'll end.
Okay, so I'll start with the injection piece first. There's
And
absolutely
PRP, if you could. A lot of people are curious
yes,
about PRP.
yes. There's absolutely a time and place for injections, and I've had patients that injections really help them. They all kind of have a different purpose. So PRP, and I'll add in PPP injections. So PRP is platelet rich, PPP platelet poor. Those are for injuries that need to heal faster or aren't healing well. Cortisone is for inflammation. Cortisone is like throwing a fire hose on a fire. So cortisone will not fix any issues. So cortisone is more so like, let's say, for example, for a shoulder, you have a labral injury, it's the middle of the season, you cannot get surgery. We might throw a cortisone injection in your shoulder joint space to put out the fire and get you to feel better so you can play. It is not healing anything. Now, cortisone injections come with some red flags. So we know that cortisone and steroids really weaken tendons. So we would never use cortisone on like an Achilles tendon, a patellar tendon, any sort of rotator cuff. We know it can degenerate rotator cuffs. So if you have doctors or anyone suggesting cortisone, which generally they don't because they know this too, uh, suggesting cortisone for any of those type of areas, I would say, heck no, do not do it.
Mm-hmm.
Um, and I
Generally,
think you,
not just for athletes.
yes, for anybody.
Okay.
And but if you have somebody, like an older woman with frozen shoulder, something like that, sometimes cortisone shots can really help them. Um, so I would say cortisone is addressing symptoms only, and it can be very effective, but it has its dangers of weakening tendons. Um, and then we have PRP, PPP. So in my experience, the research is so 50-50 on whether or not PRP actually works.
Mm-hmm.
So it's hard to say from a research perspective, but I'll say clinically, from my experience, PRP is most effective in tendons. So if you have a long-standing patellar tendonitis, a long-standing Achilles issue, that's where I see PRP being most effective. But for these people, you have to be prepared to take time off after your injection. So people who get PRP shots and then go right back to exercising or right back to their therapy program or right back to their sport is when you're going to have issues. They need to have like anywhere from, depending on the area, but like 4 days to 2 weeks of like rest once they get that injection.
Okay.
PRP shots, clinically in my experience, not effective for soft tissue injuries. So if you have a mid-belly muscle strain, we do not suggest PRP. What has been shown, and I believe in the research as well, to be more effective is PPP. I could
Okay.
not tell you why PPP versus PRP works better in muscles versus tendons, but it just does. So if your patient has a PRP injection for a muscle belly, I would consider asking their doctor, what do you think about a PPP shot instead?
And say again what
Um,
PPP is.
it's platelet poor plasma.
Okay, got it.
So for whatever reason, that is just more effective in soft tissues, and it's especially more effective in soft tissues if there's been any sort of hematoma in that area.
Okay.
Again, I'm not actually exactly sure the science behind that, but it just is.
Sure.
And I'm going to throw in one more, and that's stem cells. We see a lot of athletes and even general pop, more and more so stem cells is becoming more popular. I'd say two things. Um, Again, we have to be careful where we're putting stem cells because
Mm-hmm.
stem cells become whatever tissue, in theory, become whatever tissue you put them near. So sometimes we get patients in certain areas that get bony overgrowth.
Hmm.
So stem cells in joint spaces can be a little bit risky, and specifically stem cells near like tendinous junctions can be a little iffy sometimes.
Okay.
So that's one kind of hazard with stem cells. And then two, the thing to always tell your patients who are pursuing stem cells is, as of right now, it's not covered by insurance. So they're going to come out of pocket for it, and it's expensive. Not all
Mm-hmm.
stem cells are created equal. Most commonly in the US right now, what we're doing is doctors are harvesting your own stem cells. They stick a giant needle in your pelvis, so in your ilium, and they're pulling out your bone marrow. They're spinning it down because that's where your stem cells are, and then they're
Mm-hmm.
injecting you with what they spun down. In our bone marrow, it can be anywhere between like it's like 1 in every 30,000 cells or 1 in every 300,000 cells. To be honest, I don't remember where the decimal point is a stem cell. And that number goes down and down and down as we age.
Okay.
So you could go through this procedure, have your stem cells harvested, they could spin it down. They have no way of knowing how many stem cells they injected.
Hmm.
So we have some people that go through these stem cell procedures and have amazing results, and some people it didn't work for them at all. It's the same procedure. The difference is we have really no way of controlling the quality and the quantity of stem cells that we were actually injecting from that procedure.
Sure.
There are more facilities now that are doing umbilical cord stem cells. That tends to be more effective.
Okay. Cool. And just what are you doing education wise, or what things have you done? Because obviously you were very blessed to be in such an awesome biomechanics lab and get the opportunities that you did. For other
Yeah.
people who may, I mean, I think we'd all love that experience. Um, what are you kind of leaning on to help bolster your kind of knowledge base at this point, or maybe up to this point?
Yeah, it's a great question. From a Con Ed perspective, I personally tend to pursue courses that are going to teach me a technique that I'm not very good at or a new technique that I want to learn.
Sure.
Um, I don't pursue as many courses that are more like treatment philosophy based. I'm not saying that's right or wrong. That's just kind of what I've done in my career. And I've learned more treatment philosophy from mentors that I have in the field. So that's been more like personal education. And then the actual courses that I'm paying for are generally for me to learn a new skill that I want to learn. But that being said, you mentioned biomechanics specifically. Chris Powers at Movement Performance Institute in LA. I'll just plug him.
Mhm.
So that's who I learned from when I was at USC. And he does like a 6-month fellowship. Well, he does a year-long fellowship program if you actually want to work in his clinic and get a fellowship in biomechanics. But he also does a 6-month just Con Ed course. That's a series of courses over the course of 6 months where he teaches basically all of the lower quarter biomechanics. So you're going to learn return to sport testing with running, cutting, jumping, hopping. You'll learn running analysis specifically. You'll learn biking analysis and bike setup,
Hmm.
gait and walking analysis, all of it. So that's a really good place to start that kind of 6-month Con Ed course if you just want to learn kind of the basics of biomechanics and how to apply it clinically. And he does go
Sure.
through like treatment approaches with that as well, like how to actually retrain those movements, which I think is really helpful too, because it's, if you're going to actually treat based on biomechanics, you need to have a good basis of, motor control theory and skill acquisition and like actually how do you change the way somebody moves. So because if you're going to assess it, you're going to treat it too. So and he does a good job of integrating both of those. So I would say that's a good place to start.
Okay. And is that 6-month series of continuing ed courses, are those in person or is that a digital online thing?
Those are in person and those are in LA. Hmm.
Nice. So a bit of a commitment, but obviously a tremendous experience.
Yeah, it's one that I would definitely recommend.
Okay. Well, Emily, is there anything else you'd like to add before we close?
I don't think so, but if anybody has any questions or wants to reach out directly, they can find me on Instagram. I think Nate threw up my Instagram on there. I
Mhm.
try and answer all of my DMs and questions about that people have. So I'd like to think I'm pretty responsive on there. So
I'd
yeah,
say
it was
so.
a great conversation. So I appreciate you having me, Nate.
Oh, absolutely. Thank you. And everybody, take care until next time. As promised, guys, I told you I would try to give you a clear description of the things Emily and I talked about, especially as it relates to how to transition and progress into ballistic movements. So, just to recap, her general order of operations is isometric to dynamic to ballistic, progressing from double leg to single leg within each of those phases. So, what I think a couple things to look at if you're looking to wonder if your patient can progress, and we'll just talk about the lower extremity, maybe like an isometric squat hold or a wall sit. It's like if they can do that well, transition to a potential like partial single leg squat isometric or split squat isometric to progress single leg isometrics to make sure that has evened out between sides. If that is the case and that is good, I would progress to either double or single leg dynamic movements. And it doesn't mean that you can't be working in dynamics and isometrics together. That's kind of where the art of programming comes into play. And then once kind of the isometrics have stabilized between sides, the dynamic exercises appear similar between sides in both movement quality and strength. We'll transition to ballistic or more plyometric type motions. The way that she had described it, as far as I can remember, is double leg concentric, followed by double leg eccentric, going to single leg concentric and eccentric into a single plane, and then going back to double leg to begin multiplanar, and then double leg concentric, eccentric, single leg, concentric, eccentric, multiplanar as well. And if you say, Nate, what the freak does that look like? I will try to give you an example. I am by no means perfect. Other people have other ideas. If you have a better progression or organization that you have found, please contact me. And I'd love to get you on the podcast so that we could talk about it and everyone could be bettered because of your expertise. So it looks like a safe place to start ballistic or plyometric or power-based interventions is a double leg box jump up to the box only and then stepping down. Once that seems to go well double-legged, you can essentially do a box jump up, turn around, do a depth drop down to see how they manage eccentric load bilaterally. Once that looks pretty good, I would transition to a depth jump to where you're on top of the box, you drop, followed by a jump to where you get the rebounding cycle of the tendon to jump. And then it would appear that we would go with some single legs box jump type of activities, primarily jumping up onto the box and stepping down with one leg. I've heard mixed opinions on single leg depth drops simply because the load is so high, it may be higher than necessary for a lot of circumstances, but that is always also an option to progress to a single leg a depth drop. And then when we're going to multiplanar, I would probably think about this as a maybe a lateral box jump. So maybe jump from the side up onto the box, so you have both a vertical and lateral component, and same with the drop. So doing a horizontal depth drop to where you jump off the box sideways and land, and you do facing both directions to overload one side more than the other in the moment, but equally distribute the weight between sides. And then from there, I think it really just falls on you to know what does this person really have to manage in the sports that they're trying to get back to, and including these type of plyometric and ballistic exercises with, again, those other phases of programming, which are the isometrics and dynamic exercises. I hope that is useful for you guys in the future. I'm looking to do a section called Nate's Notes, which will be a 10 to 20 minute overview of these longer form conversations and how I anticipate applying what I've learned clinically to see if that will help anyone have a better picture if they just don't feel that they are getting as much out of the conversation, because we do go into a lot of nuances, a lot of tangents to address other things that the person I'm with feels important to how they practice. So look for that coming out in the future. But again, guys, thank you so much for watching. If you like it, please give me a rating. If you'd like to get updates on the podcast, subscribe. I now am on all available platforms. And as always, guys, happy to have you. Good luck with what you're working on, and take care.